Excellent, thank you. Well, good morning, good afternoon, and good evening. My name is Caroline Lukaszyk, and I'm the Technical Officer for Injury Prevention for the World Health Organization. It is my pleasure to welcome you to our third and final webinar, part of the three-part webinar series titled Strategies for Preventing and Managing Falls Across the Life Course, Preventing Falls Among Children and Adolescents. I'm delighted to be your MC for today's session. The key purpose of this series of webinars is to bring together falls prevention experts from across the world to hear about their work across three key populations. Firstly, older people, secondly, workers, and thirdly, children and adolescents. Through this webinar series, we hope to promote our WHO technical package for falls prevention, which was launched exactly 1 year ago today, titled Step Safely. This excellent resource, to which all of today's speakers have contributed to, is available for free download through the WHO website. I'll share a link to this resource in the chat shortly. To begin, it is my pleasure to introduce Dr. Etienne Crew, who is a Director of the Department of Social Determinants of Health at the World Health Organization, to provide opening remarks. Thank you, Dr. Crew.
Dear colleagues and friends, welcome to this webinar series on fall prevention, which we at WHO are very happy to co-host with our friends at the Monash University Accident Research Center in Australia. And the purpose of this webinar is really to discuss falls. Every year, more than 684,000 people die as a result of fall, and an estimated 172 million more are left with short or long-term disability. Two shocking statistics representing huge amount of human suffering. About 37 million falls are severe enough to require medical attention each year, of course, adding a lot of cost, human and financial, to the health system all over the world. Falls result in more years lived with disability than transport, injury, poisoning, drowning, and burns combined. And of course, the vast majority of fall deaths and injuries occur in low and middle income countries, adding to a lot of the other burden they're already facing. So falls are a growing and under-recognized public health issue. And many factors indicate that this issue is big today, but is likely to rise, including due to the aging populations as well as to increased urbanizations. The good news is we can prevent falls if we collaborate with individuals, communities, employers, institutions, healthcare professionals, etc., etc. A lot can be done to address falls, and that is what we have really summarized in the Step Safely WHO technical package, which is designed to support practitioners, policymakers, managers, researchers, and advocates to prevent falls. They're focused particularly on the three biggest at-risk groups: children and adolescents, workers, and older people. And this is why we have focused this webinar series on those three groups. We'll be focusing each of the three webinars in the series on one of the high-risk groups. So thanks so much for joining us. Please participate actively and above all, use the information gained to help us implement the Step Safely package in your country and in your region. Thank you so much.
Thank you very much, Dr. Krug, for setting the scene so excellently. So now I'd like to hand over to another WHO representative, Dr. David Mytton. Dr. Mytton is a scientist with the Department of Management of Non-Communicable Diseases, Disability, Violence and Injury Prevention at the World Health Organization. Thank you, Dr. Mytton.
Hello, everyone. It's my great pleasure to welcome you all to the third and final webinar to support dissemination of the WHO technical package for preventing and managing falls across the life course, Step Safely. Today's webinar focuses on preventing falls among children and adolescents, one of the identified priority groups in the Step Safely package. We are very grateful to have collaborated with our colleagues at the George Institute for Global Health in developing today's webinar agenda and securing our excellent speakers. We look forward to our ongoing collaboration on the issue of preventing falls among children and adolescents. Falling is a normal part of development as children explore their environment, learning to work and physically challenge themselves. It's important to note that this environment is not always very child-friendly. Minor falls are an important part of child development that help children advance fundamental movement skills and risk assessment skills. Not all falls are problematic, and as a result, our aim should not be to eliminate falls in children entirely, particularly if this would mean reduced engagement in physical activity. However, serious falls are problematic, and children are prone to injurious falls as they are naturally curious and not always able to judge risk appropriately. In 2019, falls were responsible for an estimated 31,000 deaths among children and adolescents aged below 15 years. Child fall mortality rates are up to 3 times higher in low and middle income countries than high income countries, with the world's highest fatal fall rates among children estimated to occur in the low and middle income countries of Southeast Asia and the Eastern Mediterranean regions. In order to address the growing burden of falls among children and adolescents, falls prevention and management should take a systems approach, which strives to create safer people, safer environments, and safer policies and legislation, and uses targeted prevention interventions to address the risk factors. The strength of the STEP Safely Technical Package is that it clearly lays out these approaches within an evidence-based framework for falls prevention and management. Growing populations and accelerated urbanization cause our cities to not only get bigger, but also become denser. Increasingly, people, including children, live in high-rise apartments with limited space and have reduced access to green, recreational, and safe open spaces. This urbanization creates direct risks for falls, such as falls from high-rise windows and balconies, falls from stairs, and falls from bunk beds, while creating a lack of opportunity for lifelong participation in physical activity that is necessary to develop strength, balance, and aerobic fitness required for good health. Addressing the burden of falls among children and adolescents requires a multi-sectoral approach. Fall prevention efforts can be led and assisted by all who are affected, be that communities, individuals, employees, employers, institutions, healthcare professionals, health and social care and leisure service providers, governments, and non-governmental organizations. STEP Safely is a technical package designed to support these multi-sectoral stakeholders in their work to prevent falls and prevent and manage fall-related injuries. Before I conclude, I would like to thank everyone who has been involved in the development of the STEP Safely technical package, those who have prepared the current sessions, our great speakers, and all individuals who have joined us today. Please enjoy the webinar.
Excellent. Thank you very much for that audio recording, Dr. Meddings. To write our final opening remarks, I'd now like to hand over the floor to Professor Jennifer Oxley. Professor Oxley is the Associate Director of Graduate Research and the Acting Deputy Director of the Monash University Accident Research Centre, who are also partners in this webinar series. During her career, Jenny has led sustained research program on injury prevention with national and international partners, and a significant contribution to safe mobility of vulnerable populations, is recognised as a leading academic in injury prevention research. Over to you, Jenny.
Terrific. Thanks, Caroline. Well, I'm actually here on behalf of the Acting Director of MUARC, Associate Professor Stuart Newstead. And on his behalf, I'd like to extend a warm welcome from the Monash University Accident Research Centre, affectionately known as MUARC. I'd like to welcome all participants to this webinar, which is the third in the series of the 3 sessions, and again, focusing on the important issues of falls amongst children and adolescents. MUARC's based at Monash University in Melbourne, Australia. We've had about 35 years of history contributing to injury prevention, science and practice in Australia, our region and globally. Throughout this period, we've been a very proud WHO collaborating centre, and this role is central to our vision of ultimately seeing an injury-free society. While we've still got some way to get to this point, it's important that we incorporate good science and collaboration. And the work and activities within the collaborating centre addresses key injury challenges at both regional and global levels and fosters a collaborative global network to address these challenges. Indeed, we believe that collaboration is critical in achieving change through the sharing of knowledge and expertise. And this is what this series of webinars is all about. And we very much hope that we can accelerate success in falls-related injury prevention and see improvements in global health. As a university-based research centre, our primary goal is to produce the highest quality research evidence around injury prevention, but we don't stop there. It's equally important for us to align with the WHO as a collaborating centre to translate the research outcomes into practice that will make a difference in the real world. And I think that the Step Safely technical package is a terrific example of collaboration having real world impact, and that this series of webinars is a really great opportunity to share our knowledge and expertise. So I hope today's webinar will build on the excellent work of the Step Safely technical report. I'd like to thank Dr. Etienne Crew and Dr. David Meddings for their opening remarks. Of course, Dr. Caroline Lukaszyk from the WHO was the Western Pacific region, but now is in headquarters in Geneva. In really getting this webinar series off the ground. It's been a huge effort. Last but not least, I'd like to thank the speakers who have really kindly volunteered their time today to present their work. So I hope that today for the participants, that this webinar will be of great value and really invigorate collaboration and the need to continue our efforts to reduce falls and falls-related injuries amongst children and adolescents. Thanks, Caroline. Hand it back to you.
Thanks very much, Jenny. And with those final opening words, I'm very pleased to kickstart our third and final webinar. We hope to make the webinar very engaging and interactive. And as a result, we'd really like to hear from you as the audience. So first, for this, would you please introduce yourselves using the chat function at the bottom of the screen to let us know who you are and where you're from. Over the duration of the webinar, the Q&A function at the bottom of the screen will be open, and we really warmly welcome you to add questions you may have for our excellent speakers today. These will be discussed during a panel at the end of today's session. And so without further delay, our first speaker today is Dr. Joanne Vinson. So Dr. Vincenten is the focal point for child injury prevention with Unicef headquarters based in New York. She works in the Unicef Health Group and across sectors of environment, education, child protection, urban planning to mainstream, scale up and sustain child injury prevention interventions, including falls prevention, with governments and key partners globally. Joanne has extensive experience in the field of child injury prevention in the built environment. It spans more than 20 years working in local, national, regional and global levels on program and policy implementation, academic institutions, national governments, non-governmental and intergovernmental organizations. Joanne received a PhD from the Faculty of Health, Medicine and Life Sciences, the University of Maastricht University, with a focus on implementation science and knowledge translation. Thank you very much, Joanne. Over to you.
Great. Good morning, good afternoon, good evening. Thank you for the kind introduction, and thank you so much for including Unicef and myself in today's presentation. I'm going to start to share my screen, and hopefully my slides show up here, and make sure I'm in presentation mode. Do we have everything on the full screen here? Can someone confirm?
Not yet, Joanne. Sorry, maybe perhaps try resharing.
Okay, I'll try reshare here again. So share. Okay, is my screen sharing? General screen?
General screen, yes.
Yes.
Okay, and now my presentation has gone away. Interesting. My apologies, everyone. Trying to move quickly. Is that screen sharing now? Great, I'll put it on full screen mode. And we have full screen now?
Perfect.
Great, thanks so much. Sorry for the delay. On behalf of UNICEF, we are looking at sort of more of a systems approach and supporting. So we are looking at falls and the context of that every child has the right to a healthy and safe environment. And this includes contexts and settings to reduce child and adolescent falls. So I'll be looking at this from a broader perspective. And as David and Etienne have very well introduced in this session today, the impact and the magnitude that falls have on children. And the work we've done recently in UNICEF, we've been looking at children from 0 to 19 years. So some of the numbers that you'll see on this slide might be slightly different than what was given in Dr. Medding's introduction, because we're also including in UNICEF the first 2 decades of life for children. And so as noted, this is looking at 100 children and adolescents each day, with more than 38,000 globally experiencing a fall and dying from that incident. We also know that it's between 25 and 56% of all presentations to hospitals as a result of falls in this age group. And as indicated, it's more than 80% of these falls deaths are occurring in low and middle income countries. As noted also is that this disability, it's not only is it high disability, but for children and adolescents of this age group, it comes to the top 10 causes of falls of disability in this group. And boys are at a 60% rate higher than girls of experiencing a fall. In UNICEF, we're also looking at preparing technical guidance on child injury prevention. And as part of this preparation for technical guidance, we've updated data for children's injuries, including falls, as well as we've looked at the falls prevention interventions based on evidence-based review, supported by Johns Hopkins International Research Unit. And this also corresponds and mirrors very nicely the information that we see in this Fall Safely and the Step Safely package of technical information. And as UNICEF works with many country offices, we're looking at the most effective way to spend our resources and our time. So we have been putting forward the most evidence-based information as recommendations for our country offices to take up, which I've put here on the slide. So we've looked at effective and promising interventions that come through. And as I just said, these mirror very nicely and reinforce what is being put forward in the Step Safely package. And it does emphasize the fact that we can be having these positive and effective solutions that we can be putting in place. So we do have the means to be able to make actions possible. And these are happening at different levels that we can be doing at community, at regional, and at global efforts to make these happen. When we're looking at these actions, you'll see that there's a range of activities that can be happening at an educational, at an environmental modification stage, or also at a policy enforcement aspect. So all of these, and as mentioned, a multifaceted approach combining these aspects are most effective in order to make a positive change. Why is UNICEF engaging in fall prevention? As we've noted, is that UNICEF is now taking child injury prevention as part of our health portfolio within our organization. And we are demonstrating that we are looking at, as I've mentioned earlier, the first 2 decades of life. Most people might be familiar with UNICEF as dealing with primarily 5 and unders, which has been the case. But in the last few years, our previous executive director emphasized how important it was for us to be looking at a broader life course, which included the first 2 decades. And if we follow the epidemiology of what's happening for children over the age of 5 years, we know that the leading cause of death and disability for children over 5 and to age of 19 is child injuries. Therefore, we are taking that role of including injuries within our mandate and scope of what we're doing to make a difference. With regards to falls, we now have looked at how we can include falls into our indicator set relevant for our 2022 and 2025 strategic plan. It's within our Healthy Environments for Healthy Children framework and our global education strategy. And the reason why this is important is we're trying to, within our own organization, demonstrate how child injury prevention, in particular, as we're talking about today, how falls fits into this realm of what we're working on. We now have 190 countries, country offices for UNICEF globally. And if we place that program of falls within our area of emphasis in our plan, and we also now have it as part of our strategic monitoring questions that we ask our country offices each year, which activities they are doing overall. We now include asking about markers on falls prevention, which now raises that question to our country offices about engaging in this important activity and prevention measures. Our approach, as we said, is looking at a multifaceted approach across many sectors. We want to firstly raise the fall awareness that it is the serious issue and that we're having this come forward in our work on our technical guidance that we're giving to our country offices and encouraging our country offices to identify that as an issue within their child injury prevention programs and to work with their key stakeholders and partners in their countries to move that forward. We're producing and using standardized tools and resources for country offices in partnership with government and key stakeholders when we want to assess the issue, implement the evidence-based intervention, and monitor its impacts. And we are, again, want to compliment WHO on this excellent resource of Step Safely that we can use such technical packages to provide to our country offices that we can then be working with those key stakeholders so that we're using a consistent and standardized approach in those tools, because we also want to be able to review the results that are happening between countries and share successes and ways forward to move the agenda as we ideally want to achieve. Our other approach is we want to mainstream falls prevention into broader primary health care and public health approaches. And for UNICEF, it's important for, especially in our younger age groups, that we do that within our early childhood development programming and through home visitation programs. And I'll explain this a little further in our next slide. Then we want to also support the piloting of policies and programs in countries that will then improve scale and scaling up and sustainability in communities and countries. So we're looking at, as I said, this broad approach of a sort of a system strengthening in order to engage our country offices and key stakeholders in this important area of work. For home visitation programs, as an example of one of our targeted at-risk family programs that we run, and as noted in the literature review, that home visiting programs are an effective, promising intervention that can make a difference to help reduce falls. We have a home visiting program that is very diverse, it's a model that carries 12 different modules. And one of those modules is on home environment and safety. And within that home environment for safety, and this program particularly is for under 5s, is that we're looking at how we can also include, and we have included, home falls prevention for under 5s within this package and module. For example, in Kazakhstan, they have now run this pilot program beginning in 2014 and introducing different modules, including falls prevention. And now they've looked at this point in time, that they've changed this pilot and working with government offices to make this an actual compulsory aspect of their child visitation programs within government. So it's become a standard policy of operation, and it's been mainstreamed into how they're doing their early childhood development work with families at risk. By doing such standardization of programs, we can integrate and we can scale up, and we make this a more sustainable approach by providing this early childhood development for young children and their families are at risk. So then the likelihood of us being able to give this equitable opportunity for those families is consistent throughout the country. And we want to be able to do that with a number of countries. When we at UNICEF are looking at how we approach falls within child injury prevention, we are looking at the fact that this is, as I said when I started this presentation, it is a right. We at UNICEF believe it's a world where no child dies from a preventable cause, and all children reach their full potential in health and well-being. And we include that for injury prevention, and including, as we've mentioned in this presentation, that is also for falls. I'd like to thank all of you for this opportunity to share the broader perspective and integration process that UNICEF is going through with our country offices and the partners and key stakeholders that we can work with in each of our countries to bring forward the Step Safely package and to make sure that we can integrate that as best as possible in a sustainable way. Many thanks.
Thank you very much, Joanne. Thank you very much for the excellent presentation, for highlighting the approach UNICEF is currently taking towards addressing falls, and particularly for sharing detail around the home visitation program. It's very interesting, and we look forward to our ongoing collaboration in this space too. So it's now my pleasure to hand over to our next excellent speaker, Professor Julian Wooten. Professor Mytton is qualified in medicine and has worked in primary care, community pediatrics, and public health before joining the University of West England in 2012. Julie is a professor of public health and leads the global health research theme in the Centre of Public Health and Wellbeing. Her research interests include building an evidence base and strengthening capacity for injury prevention and policy. Thank you very much, Julie. Over to you.
Thank you very much, Caroline, and thank you for giving me the opportunity to join you today. I will share my screen. I'm going to give the first of two presentations where we're going to give an illustration of a country-specific approach to child injury prevention and falls prevention. And I'll be talking on falls in children and adolescents in Nepal. I'm going to first illustrate the context in which children grow up in Nepal and some of the risks for falls that they encounter, and then describe some of the evidence that is available so far in that country for falls prevention, and then think about how the Step Safely guidance could be potentially applied in this context. So despite increasing urbanization in Nepal, the majority of the population still live in rural communities. And this photograph illustrates a typical Nepali home, which is a two-story wooden structure with an external open staircase leading to a balcony that runs around the outside of the building. So clearly illustrating some fall risks in the home environment. There are very few designated formalized play areas for children. Therefore, children play mostly in and around the home. And of course, because of the topography of Nepal, many of these rural communities are surrounded by steeply terraced agricultural land. This photograph illustrates community in the low hills, and of course these terraces only get steeper as you move into the high hills and into the mountains. In urban settings, children mostly grow up in brick and concrete homes, which are often multi-story, but again with very little designated play space. So play is usually in the immediate forecourt of the home. Here we illustrate a home, a shop front actually on facing onto a road. The children's play area is the pavement outside the home, and you can see a baby walker here with a road on one side of it and a fall of about 1 meter on the steps down towards the shop front. Even as we approach the southern border of Nepal with India, where you have the plain areas and much more open space for children to play, these play areas may not be safe. In the absence of a national refuse collection system, falling in these play areas may mean falling amongst rubbish. So there's sort of real risks of falling even in these flatter areas. Now, as children grow, they're much more likely to start contributing to the household activities, and that will mean supporting their families, working on the terraces. And many homes in rural Nepal will have a buffalo for milk, and the buffalo are fed with leaves from trees. So often people will climb trees in order to cut down the branches to feed the buffalo. And falls from trees are the leading cause of spinal injury in Nepal. So hopefully that gives you a flavour of some of the context in which children are growing up in Nepal. So if we now start thinking about the evidence that is available, there's actually been a relatively limited amount of research that's been done on fall prevention in Nepal. So what I'm going to do is start to illustrate, is to show you some of the evidence that's available that indicates the burden of falls amongst children and young people. This was a study that was conducted by Pant in 2009, which was a community household survey of almost 3,500 homes, asking about falls in children under the age of 18. And what they were able to illustrate was that actually falls are very common in children from 15 years and below, and particularly the peak age for falls in this group were the 5 to 9-year-olds. This study looked at quite serious falls. They wanted to find falls that had resulted in 3 or more days for that child being out of their usual activities. They also were able to clearly indicate this inequality in gender, with boys having almost double the risk of falls compared with girls. In 2015, BATA conducted a study, another community household survey, but this time specifically looking at homes with children under the age of 5. And what this team did was they, as well as asking about fall injuries in the under 5s that had resulted in a day or more of being unable to conduct their normal activities, they also did a home hazard assessment, and they assessed the homes in their study for these 5 fall hazards. And what you can see from the table on the left here is that almost every home they visited had 1 or more fall hazard, with almost every home having an absence of rails on the stairs, almost every home having absent window guards, and half the homes having no guard on the balcony. What they were able to demonstrate was a very clear association between an increasing number of fall hazards and an increasing risk of having a fall injury. In 2019, the Nepal Injury Research Centre team worked with 2 emergency departments in Makwanpur district in southern Nepal to record every injury attendance that attended those 2 ED apartments. And over the course of a year, they recorded over 2,500 injury attendances in children under the age of 18. We can see that falls were the commonest cause of attendance in the emergency department. And again, the distribution of those injury attendances was very similar to that found in the community household survey conducted 10 years earlier, with most of those injuries occurring in the under 15s and the predominance in the 5 to 9-year-old group. Again, the more than double the attendances for boys compared with girls. Now, we know that policy and legislation can be a highly effective means of preventing injuries. The Nepal Injury Research Centre team also conducted a review of existing policy and legislation in Nepal that had the potential to help prevent a whole range of different injury types. And on this slide, I'm showing the results about fall injuries. We compared the existing policy and legislation with existing published WHO recommendations for fall prevention that existed at the time that we did our study. And of the 9 WHO recommendations, what we found was that only 2 of them had existing policy and legislation in Nepal that actually supported that activity. So there was legislation and it was implemented in order to promote the use of public health education and to promote the provision of acute care for paediatric injuries. But when it came around to things like the provision of window guards for high-rise homes, the use of stair rails and guards, the regulation of furniture to make it safe from falls for children, although there was some policy that sort of touched on this area, it either wasn't implemented or it wasn't funded. And that there were a number of areas where there was no policy currently in place at all. So I think there's huge potential for policy to make a difference in this context. So how could the Step Safely technical guidance recommendations be applied in the context of Nepal? And I think there are probably 5 main areas where it has the potential to make a real difference. And the first of those is about the provision of information on child injury risks to parents, and then the provision of support to those parents to act on that information. This may involve the use of home visits and safety assessments, the active promotion and enablement of the use of stair rails, gates and balcony rails, the fencing of steep drops, and the provision of child-friendly play areas. And I think we have reasons to be optimistic about the potential to make a difference in Nepal. In 2014, PANT conducted a study in rural communities. There is a network of mothers groups that meet on a monthly basis across rural communities in Nepal. And these mothers groups are facilitated by a female community health volunteer who works with the mothers around a range of health and education activities. And what PANT did was to develop a resource, which is illustrated here on the left, which showed typical home scenarios and indicated some of the fall hazards and other injury hazards for children in those settings. They then trained the female community health volunteers to use this resource with their mothers groups, and they tested it out with 10 mothers groups in a ward in rural southern Nepal. And what they found was that all of those mothers groups were very actively receptive to receiving that injury prevention information. And the photograph on the right here illustrates the outcome of that, which was where one community, the mothers identified that the well in their village was a real fall risk for their children, and they successfully advocated for having the height of that well ring raised to reduce the fall risk in that village. So I'd just like to thank my collaborators in Nepal for generating the evidence that I've been able to share with you this morning, and to again thank the WHO for giving us the opportunity to illustrate Nepal as a case study for the Step Safely guidance. Thank you very much.
Thank you very much, Julie. Thanks for providing this very important context. The issue of falls among children in Nepal, and I'm sure in many other low income contexts as well, for sharing this immense body of work today as well. This really does help us understand the practical application of Step Safely at the community level, at the policy level, and we hope this inspires a lot more conversation and discussion during the panel we will have later. I'd now like to introduce Dr. Margie Hayden. Dr. Peden holds degrees in nursing epidemiology, is an internationally recognized injury epidemiologist. She headed the unintentional injury prevention team at WHO for 17 years, leading both world reports on road traffic injury prevention and child injury prevention. She is currently the head of the George Institute's Global Injury Program based in Imperial College, London. She co-directed WHO Collaborating Centre on the Injury Prevention and Trauma Care. Thank you, Margie, over to you.
Thanks, Carolyn, and good morning, good afternoon, good evening to everyone. Thank you to David, Etienne, Caroline, and you, Jenny, for this really great initiative. So let's get to it and see if I can share my screen. Oops, sorry. You can see it? All right, so So we've heard from Joanne about some of the global numbers, and David and Etienne, and also about some of UNICEF's initiatives, and from Julie about the kind of who, what, where, when of fall injuries amongst children in a developing country setting. What I'm going to try and do in the next 10 minutes is try to add to this puzzle, this picture basically that we're painting, by shedding some light on what we think could work or would work in a low resource setting. And at this stage, I just need to introduce my colleague Shanthi, who I know is one of the participants. This is part of her doctoral thesis. And so, Shanthi, I will not give away too many of your statistics and really just try to talk around the issues. So let's just start then by reminding ourselves what that Step Safely package says about fall interventions, in particular in the home. And I think Julie has already mentioned this, that parental information to reduce risks around the home and parenting programs for high-risk families are recommended interventions. And then there are other interventions around home visitation and around risk elimination, putting up barriers, etc., and discouraging baby walkers. I was really interested, Julie, to see the picture that you put up of the baby walker with the road on one side and the fall on the other side. So that's just a reminder of what it is that we think works. So what we did, or what we set out to try and look at, was whether we can translate some of the interventions that have been applied in high-income countries to low and middle-income settings. And a number of my colleagues here in the United Kingdom have done very successful work translating or working around a similar concept to the Finnish baby box, which is what you see here on the left-hand side, which was a concept that was designed many years ago in Finland. And every mother receives this box that has not only clothes and safety equipment to prevent injuries in young babies, but also doubled up as a cot, because decades ago, babies used to co-sleep with their mothers, and they had high incidences of SIDS, sudden infant death syndrome. And this box concept worked extremely well. So our hypothesis, I guess, was whether this could be translated, in this case, to a Ugandan setting, which is where we conducted the study that I'm going to talk about a little bit this morning, in a city called, or a town called Jinja, which is a secondary city. I'm not sure if you can see my pointer, but it's kind of towards the east of Uganda, and it's at the source of the Nile. And it's an impoverished community where most people live in informal settlements. The study that we did, we wanted to find out kind of what child injuries meant in context. And so we used mixed methods, both qualitative and quantitative methods, to understand better how the children were injured, what the risks were, and then come up with a proposal of a community-driven intervention that we could take forward. And the study related to all child injuries. I'm just going to separate out now some of the information then about falls specifically. And as you can see, like Julie's study that was done in Nepal, when we did a community household survey, it was no surprise that falls came out as the leading cause of child injuries to children under the age of 5. Those falls were slightly different to those that Julie mentioned. The falls that are happening in Jinja in Uganda are off beds, and this is the area that I'll continue to focus on. Children tend to sleep in triple bunks, and they play on these triple bunk beds because space is a premium in the housing. And also they fall down pit latrines. So latrines are dug outside, and they either have very rudimentary covers, or in many cases, as Prash and I saw when we went to Uganda, they're not covered at all, and in fact are a severe fall and drowning, in fact, risk for children. So when Prash, we did a risk assessment as well. We went to the homes in the homesteads and checked out what risks there were around the home. And when we looked at the association between the hazards and falls, we noted one that came out very strongly, and that was if there was nothing to break the fall, if there was no cushion, no mat, no carpet, no something to soften the fall as children around children's beds, that they were more likely to be injured. And so that's the area that I'm really going to focus on now. What we did was we actually engaged mothers. We decided that we would, during COVID, and you can see the mothers here are all wearing masks, actually involve mothers in trying to unpack more this issue of child injuries, and in this case specifically about falls. And we equipped them with cameras, and they went out and took photographs of risks that they identified, and then came back, and through focus group discussions, we unpacked more the issue of falls. And I'm going to show you now a couple of the photographs that the mothers themselves took that we then discussed with them. And this first one shows you kind of the cramped surroundings that children live, sleep, eat, play, all in one area, usually a shack that primarily has one area for eating and cooking and sitting, and maybe another area where everybody sleeps. So this is the kind of area that children live in. These are the areas, similar to the photograph that Julie showed as well, that children are having to play in incredibly unsafe areas. In this case, you know, no barriers to the stairs, concrete, broken concrete, really, really unsafe areas. They also, funnily enough, we have a photograph of them playing in amongst waste, whether it's domestic waste or medical waste, and obviously huge injury risks there. And this is where children tend to play. And these are the triple bunks that we talk about. And you can see how many of them are squashed together in one tiny area here. And so children have nowhere else to play. And so, you know, children use things in ways that you and I as adults would never think of or never dream of. And so these beds become their play areas. So our next step was to look at this more with a multidisciplinary lens. And so we engaged with our colleagues from Design Without Borders in Africa, who are engineers. And using this human-centered design approach, we worked collaboratively with the community to look for local, affordable, but evidence-based interventions. And in this case, I just want to talk a little bit about what we did in order to develop an intervention that we hope to test that will reduce falls. So we went through the process. We provided the engineers with our research from hospital data, from the community survey that we had done. And together with the community, they came up with some ideas. They synthesized, they looked at building opportunities, they brainstormed with the community and conceptualized something that they thought would work. and then went on to prototyping. And as you can see on the right-hand side of this column, the concept that the engineers came up with something akin to a tatami mat, which gets used in Japan, which is really quite a thick, spongy, layered mat that is multi-purpose. It can either be used on the ground, or in fact, it can be stood upright and used as barriers, or even on the wall as shelving. The idea then was to look to see how we could design and produce this mat locally, so that we could also at the same time encourage a micro economy in the country. When we spoke with the community, they are incredibly poor. I mean, I think I'm stating the obvious, but one of the things that they didn't want to pay for or pay too much for was safety. And so the idea of engaging with local crafters to source and identify a locally available free material to develop the mat was what we went for. And as you can see here, the crafter is developing the mat, which has a wooden kind of structured base, and then on either side it has these wooden dowels that are from locally grown trees. This is what the finished mat looks like once it's been woven and developed. And this is, we propose that these types of mats be placed around the beds that you saw in the homesteads, so that when children do play and fall or fall out of those beds at night, that their injuries are reduced because of the cushioning. Obviously, we're not going to get rid of the fall completely using this, but it is an option that we would like to be able to test. So, Carolyn, in conclusion, I really just want to say that the bottom line is that really this issue is multi-sectorial, and I think that David talked about that. I think we pay lip service to that. I think we really have to look at co-benefits of all our interventions, not just injury specific. In this case, as I mentioned, we're trying to build an economy, build a microeconomy, engage the locals. As Julie mentioned, there's always this group of willing mothers who are around. So involving mothers in and empowering mothers to actually take care of their children, not only from a communicable injury, a communicable disease point of view, but from injuries and violence as well. But this important aspect of the social determinants is really critical. And so we have to look at the context. It has to be context specific. So in Nepal, Julie needs to look at stair barriers and other barriers around balconies. Here in Uganda, it's much more around falling out of these beds and falling down these pit latrines. So it's really time to think out of the baby box, or out of the box, so to speak. And the use of qualitative research techniques is really critical in order to unpack this. I really have to say that I have been humbled doing this work. Even being born and brought up as an African, I still look at injury prevention with my Western lens, with my Western glasses on. And when you go into communities and you really unpack what is there and what needs to happen, it really has to be a bottom-up approach. It is time to decolonize injury research and stop trying to impose interventions that we think will work. You know, when I worked at WHO, we always used to say things like, we know what works in high-income countries. We just have to test them in low-income countries. No, we don't just have to test them. We actually have to dig deeper to understand what the actual issue is and how locally we can work towards solving that. So yes, we have a step safely package, and yes, it has the concepts there, but we really do need to contextualize this. Oops. So it goes without saying to say that this research wasn't done by me specifically, and I really have to thank Shanthi and Charles, who are early career researchers in Uganda and here in the UK, my colleagues, Olive Kubasinya and her team at Makerere University, and Lawrence and his team in Design Without Borders. I just want to end with one quote and have stolen a little bit from what David said in his opening statement. And that is, children are never going to learn to walk if they don't fall. But what we have to do is to prevent them from being injured. Thank you very much.
Thank you very much, Margie, for that very interesting and thought-provoking presentation. Of course, again, taking a deeper dive into context-specific risk factors for falls in Uganda, but very importantly, thank you for sharing the design process taken around developing and implementing local falls prevention solutions. And again, I also should say, Prasandi, all the best for your PhD. This looks like it's a very impactful and important piece of work. So thank you very much for sharing this. Before we move on, I would like to remind everyone, please do enter any questions or comments you have into the chat. We'd also really appreciate if you do introduce yourself in the chat and tell us where you're dialing in from, so we can better tailor our conversation and discussion during the panel as well. So please don't be shy, and we'd love to hear from you. We're now moving on to our final panelist for today's session, Dr. Shanthi Ameratunga. Dr. Ameratunga is a Sri Lankan-born, New Zealand and US trained pediatrician and public health physician with a 20 years international experience, taking a life course approach to injury prevention, trauma outcomes, and disability. Her extensive research collaborations in New Zealand and the Asia Pacific region have focused on informing sustainable policies that eliminate health and social inequities. She holds honorary professorial appointments at the University of Auckland, Monash University, the University College London, and has published over 350 articles, serves on multiple advisory committees, including WHO Unicef Lancet Commission, the Future for the World's Children. Thank you very much, Shanthi. I'll hand the floor over to you.
Kia ora tātou katoa, and Ayubovan and Manakam. Greetings, everybody. It's a real pleasure to join this wonderful panel and this very special occasion. I have to say, I found the package when that was first being sent around for review and comment really interesting. And I think the final product is extremely pragmatic and practical. And I highly recommend any of you working in this field. And I really hope, I was asking that question of Caroline, who else is in this panel among participants, because I hope you're from all over the world, maybe new to research, maybe new to injury. I think I would strongly recommend that you really have a good look. And if any of you are researchers, I'd also strongly recommend the evidence technical document that's behind it, which I think was also very well done. I'm going to share my screen and see if that comes through. Is that coming through? Yeah, cool. So my role actually has been made incredibly easy by pretty much everybody else having spoken about almost everything I had to say. But my interest here is probably just to kind of synthesize some of what we've heard. I think especially the overall context setting that Joanne did for us. Julie and Margie have both really done the deep dive into a particular context where they've shown us through the work they're doing with their collaborators in Nepal and Uganda, what the issues are in a way that actually helps understand the spaces from which the challenges come, but also where the solutions are. I think the real possibility that might be just left for me to just look at the prevention continuum. That is, we're not just talking about prevention, but also when prevention has failed. And I'm going to basically use my pediatric youth health. I'm a youth health physician. That's where my main training in pediatrics focused, just to kind of probably highlight a few issues. And I'm not quite sure how many of our participants are from high-income countries, I have a final point for any of you, as I have for myself, working in New Zealand now. I don't think we're off scot-free. I think we have a lot to learn and a lot to be actually quite uncomfortable about in terms of what's not happening in countries like New Zealand. Just want to basically indicate the main thing I want to point out from the step safely evidence in the technical package is we're talking about an epidemiological scenario that is now well established. It's the 12th leading cause for children and young people, particularly in the 5 to 9 age group and the 15 to 19 age group for deaths. 12th leading cause of fatal injuries and fatalities. And the other thing is, of course, in almost all the age group, we're looking at child to adolescents, it is a very much a leading cause of hospitalizations. Those rates are particularly high in low and middle income countries. And if you look at the evidence technical document, this is a particularly high issue, a problematic issue in Southeast Asia. Now, I was interested with what we've been hearing today about interventions, and I think they're all incredibly important ideas to think about, because if you look at the published evidence, and the levels of evidence were analyzed quite carefully in the background document to the step safety package. When you look at a sort of a unimodal, that's just one thing at a time kind of approach, whether it's the settings are home, school, playground, clinic, or community, the evidence was modest to actually sometimes weak, with relatively few exceptions, like the window ledge, children can't fly kind of information that came from the US in terms of some areas where there's clearly pretty strong evidence. I think a big reality here is that maybe publications haven't kept pace with what people are learning on the ground. And I'm really excited by, as I'm sure all of you are, the kinds of information that Julie and Margie shared about what's basically being developed on the ground by people who know their communities best and their own conditions and scenarios best. For me, I think the key thing that I take from all of this is the importance of context, the importance of a systems approach, and understanding the developmental trajectories that young people are on as they navigate their environments, and the environments in which that development occurs, whether this is physical environments, health care environments, or the social systems that they have to essentially rely on when things don't go according to plan. So I'm going to basically talk a little bit now about those just briefly. I think the point that's already been made, and we won't be walking, none of us will be walking if we hadn't fallen. And so it's not basically an issue of actually just trying to stop children from falling at all. It's actually about just making sure that if they fall, they're not going to fall in a way that's a serious injury, death, or a disability. And I think the other really important issue for us to realize is I'm glad Unicef, Joanne, has extended your reach to 18, 19. That's only another 2 years, but the reality is development happens across them. There's huge transitions that are happening in those age groups as the adolescents are aging. And it's a developmental trajectory that is very, only in a very limited way attached to the chronological age. So what a 15-year-old is expected to do in Sri Lanka or in some other country may not be the same as what a 15-year-old is meant to be doing in possibly New Zealand. Sri Lanka is probably not a very good example of this, because children in Sri Lanka are meant to be always at school. I think the issue here I'm pointing out is the kinds of realities of the engagement, the social participation, and the employment participation, the role children play in their families varies substantially. Actually, it can also vary, as we've probably seen with COVID in some of our countries that might be even high-income countries, varies within our own countries. There's a huge gradation of what young people end up having to do when things become problematic economically. There's another aspect of adolescence, of course, which is it is their duty to take risks. If they don't do that, they're in fact not actually challenging themselves to develop their own sense of agency, their own sense of autonomy, their own degree of independence. And obviously, physical activity is a huge part of opportunities to be well and thrive from a health point of view. So I think I really like the comment that's in the step safety document itself, which is talking about the safe systems approach. David's talked about that in this opening. And I think we really are here to talk about steps that will reduce the chance of a fall occurring and the amount of harm that such a fall actually imposes rather than just falls themselves. Just going to now just also remind ourselves about one other aspect, which is an issue that we often think about disability in this context of, when prevention has fall as an outcome of injury, but children living with disabilities, regardless of they're due to injuries or developmental issues or chronic conditions, they navigate the same environments that Julie and Margie have talked to us about, and the hazards they experience and the way in which they're at risk is obviously hugely greater. And systematic reviews written on this topic, falls are among the commonest of the injuries, severe injuries these children actually face. And the other aspect realizes when, regardless of whether people live with a disability or not, the kinds of injuries that are especially challenging and that could have lifelong consequences are injuries like traumatic brain injuries and spinal cord injuries. They may be, fortunately, not the commonest injuries, which are usually extremity fractures or soft tissue injuries. But when these other injuries, particularly from heights, occur, they can be disabling to a point of much incredibly difficult, not just for that child and their future, but all the support that they need and the caregivers' responsibilities as well. So it's a huge concern, and we should not be forgetting the significant impacts of falls for children living with disabilities because the environments they navigate are inherently unsafe. I want to very briefly look a little bit at a particular context, and I worked for a while in the Pacific Islands, because obviously New Zealand is in the Pacific, and we have plenty of colleagues and communities from the Pacific Islands living in New Zealand. But I was also working on a collaborative project, and this came about because one of my colleagues was at that stage the Dean of the Fiji School of Medicine, looked at, he said, look, this is the picture you see, the satellite view of the Pacific. If you took a photograph of the Pacific, this is what it looks like. But in that area right in the middle, which is not lit up, there are 22 sovereign nations, island countries, that are very tiny countries, but they are not basically without challenges, and often they're out of sight and out of mind. So he said, look, we've got issues with injuries. Can you please come and we can work together and figure out some things that we might need to be doing. And I know there are other people on this panel who are very aware of work in the Pacific and have helped generate further evidence and interventions, but I want to tell you a little bit about what we learned and the implications for falls. So this project was funded by the Wellcome Trust and the Health Research Council of New Zealand. I had colleagues that I was working with at the Fiji National University and the Ministries of Health in Fiji, Samoa, and Palau. The main thing I want to point out is while that project was focusing on road injuries, they started off by setting up a trauma registry in all of the district hospitals in Fiji, and basically identified using the WHO Injury Surveillance Guide for the minimum data set. It was published quite a long time ago, Margie will remember, but they very acidiously developed, adapted that and implemented that in all the hospitals and collected data and were totally struck by how we were doing a study on road traffic injuries and said, my goodness, look at this, it's falls. So, okay, we can't change the direction of the project, but we basically realized that in a study that then actually identified using that injury surveillance, what was happening in Fiji for children and for youth. And there's two papers that are published that I've mentioned here. And in fact, another paper that looked at traumatic brain injury in Fiji. The big issue that came up was falls. And the context was very much around what happens in an agricultural economy, where children are often out there picking coconuts, basically being out a lot, they're spending a lot of time outside, and having exposure to hazards that were not necessarily seen within the health system as their business to prevent. What was really exciting also about this project, and I thought might be useful for us to be aware of, and both Julie and Margie's presentation has talked about how data context is vital. I'm just going to focus here on how the Fiji-based injury managers on the TRIP project, and want to particularly acknowledge Dr. Iris Wainingolo, Dr. Berlin Kafua, both of whom are from Fiji, and Dr. Josephine Aumea-Herman, who's a Cook Island public health physician. The three of them basically found there were several things that became evident, which I think will resonate with the kinds of issues that the technical package that Step Safely asks us to be conscious of. They were very aware that data was being collected, possibly not in a very coordinated way, by several different people. So nobody actually had the overarching picture, but several people had angles to that information. The quality and the standardization of that data and the duplication was a challenge. And they really recognized when they came together around this project, and they were very fortunate. These two young emerging researchers were made the heads of an accident and injury subcommittee in the Fiji Ministry of Health during that particular period. And they basically got stakeholders together, looked at what the minimum injury surveillance information was providing, recognized the importance to complement that with contextual data. So absolutely concur with Margie, what Margie has said about quantitative and qualitative data. And most importantly, they actually absolutely recognize the need to co-design both the data collection and monitoring aspects, but the prevention systems that involve service providers, policymakers, researchers, and most importantly, community stakeholders. And some of the strongest advocates, I'll have to say, who were speaking most loudly that I remember for the falls prevention agenda, even though our project, as I said, was on road traffic injury, were the rehab physicians. And they were really concerned about the challenges they faced in providing services for people who had spinal cord injuries and other significant injuries. That basically, in a context like Fiji, or in less resource setting, basically the opportunity for enough physiotherapists, occupational therapists, the kinds of things we might take for granted in high-income countries was so much more challenged. So I would just want to remind what actually the Step Safely package recommends, and very strongly indicate that these are highly aligned to what I remember were uppermost in the minds of my research manager colleagues in Fiji. That is to review all the available local, regional, and national data, identify and consult with the relevant stakeholders, talk to health professionals about the fall injuries they see. They were very strong advocates, very powerful advocates, and then understand the risk factors, both in terms of population groups and the locations. And then through that, understand, okay, where do you need to basically work? And I really liked how Julie, for example, talked about what the intervention packages, kind of help mapping them across. Will we know what works? There are recommendations out there that WHO has, and maybe some areas that are currently yet to be implemented. Shows things that actually can be done without saying we're starting from ground zero. And so we really need to then identify the policies and regulations that could be strengthened and have a very strong focus on audit, monitoring, and evaluation. I want to also, it was just make a really significant, for me anyway, a plug for understanding what happens when prevention fails. Now, Step Safely talks about the importance of pre-hospital care, hospital, and that particularly knowing that in many contexts, bystander first aid is perhaps the most important thing, ensuring people can get to the most appropriate destination as quickly as possible. And there's a lot of work that WHO is doing with in-country colleagues in this area, as they are also on the trauma care pathway, hospital care in particular. I think with regard to appropriate health professional training, I particularly want to acknowledge the importance of not just surgeons and doctors, but physiotherapists and occupational therapists. These are sort of professional groups that are seriously important and often very much lacking in capacity. Extremity fractures, as I said, are common, and for that, but they could be seriously disabling if they're not managed properly and set properly. Their children may not ever be able to use their arm or their leg in the way they could have otherwise. And head injuries and spinal cord injuries obviously have a much bigger impact, as can be life-threatening or disabling. I want to note here a few issues that, while we can talk of those in generic terms, there's particular issues for children and young people. They are reliant for their access on caregivers, parents, family, community. They're quite dependent in that sense. So the awareness of communities to basically be able to access the right support and had that sense of entitlement to get it, and more particularly be visible enough, it's not their issue, services to be conscious enough of people's needs to ensure those families that are most marginalized actually get the support their children need. The other issue I want to point out for children and adolescents is that even minor deficits, and getting back to pre-injury health is not good enough when it comes to children who are in a developmental trajectory. Even minor deficits can have major impacts on education and future employment, particularly if they have issues with behavioral issues or mobility issues. And mobility issues in a context in some of these areas basically means they can't possibly get access back to school and so many types of employment. And there's increased vulnerability for underserved communities, particularly in the least resourced areas, but actually this is one that is highly pertinent for countries like New Zealand as well. That's due to poverty, marginalization, indigenous populations, people living with disabilities. There's a range, and you know them all. You know who's less served than others. And that inequity in care can be a seriously damaging impact that really is totally unjust. I want to note here, just pretty much end with on this point. I mean, Safe Kids Aotearoa, which is the New Zealand equivalent of Safe Kids, is led by a dearly valued colleague of mine, Martha Hunt, who's an Indigenous practitioner. And they have as their strongest agenda the equity issue, the issue of being responsive to the needs of Indigenous people, and certainly being responsive to people who are communities that are poorer. Now, this is an issue in rich and poor countries. And I just want to particularly note that this is where I'm saying we're not getting off scot-free thinking we're doing well just because we're a rich country. And I want to end by just reminding ourselves this picture on the left is a picture from the Step Safety package, which I really like because it's saying this is not about basically wrapping up kids in cotton wool and stopping them from doing stuff. We want them to do all the stuff that is fun, but also important for their development. And I want to end by also acknowledging my team that I worked with in Fiji during the TRIP project, and hand the role back to the chair of this program. Thank you very much.
Thank you very much, Shanthi. Again, an excellent presentation to finish up today's webinar discussion. So again, thank you very much for highlighting the importance of having quality injury burden data to really inform what interventions are developed and implemented, also discussing some of the challenges you faced in collecting and identifying this data. Thank you also for reinforcing what Margie and Julie have discussed in their presentations around the importance of working with local partners and stakeholders to ensure the effectiveness, reach of equitable falls prevention and treatment interventions and programs. So thank you very much, Shanthi. So we have now heard from 4 really exceptional presenters, which have introduced a broad number of complex and very interesting topics for us to unpick and discuss further. And to do this and to help lead our discussion around this, I'm very pleased to introduce Ms. Erica Edmonds. So Erica has over 25 years experience as an employment lawyer and senior HR practitioner who has worked in the area of workplace health and safety, diversity and inclusion for 25 years. She's also an experienced non-executive director, in which capacity she's presently chair of Kidsafe Victoria, vice chair of the Child and Accident Prevention Foundation of Australia, non-executive director of Women's Housing Limited, and former Consumer Affairs Victoria representative on the Building Advisory Council, providing planning and regulatory advice to the Victorian Planning Minister, in which role she was instrumental in the implementation of Victorian pool safety regulations. I see we've had a number of questions come through to the chat. And so in this case, I will now hand over to Erica to facilitate a panel discussion with our excellent speakers for the remaining 40 minutes of our session today. Thank you, Erica.
Thank you, Caroline, and thank you firstly to the speakers. Absolutely fascinating and quite heartbreaking presentations, which hopefully is the point. As Caroline said, I'm joining you from Melbourne, Australia, and so I would like to firstly, from my perspective, acknowledge the traditional owners of the unceded lands from which I join you this evening, which in my case is the Wurundjeri Woi-wurrung people of the Kulin Nation, and to pay my respects, my deep respects to their elders past, present and emerging, and also to any First Nations people joining us on this webinar this afternoon, this evening or this morning. From my perspective, Jonathan, thank you. A couple of really great questions that you have popped into the chat here, which arose from Joanne's presentation around Unicef and the age groups. And Joanne, I also noticed that you did make one response in the chat there. But the query is around, again, why not extend that the work that you're doing up to the age of around 25? If I can just hand over to you to tell us and explain why, that would be great.
Great, thank you very much. And thank you, Jonathan, for your question. And being a UN organization of UNICEF, we of course have to look at what scope and what age. So it's not just necessarily only our child injury prevention and falls activities that we look at, but overall as an organization, we have to examine which age groups we're looking at. As I mentioned in the presentation, for many years, and actually many people still see UNICEF as focusing on 5 and unders, and that's sort of where we've begun and where we still spend a great deal of time of our efforts. But as I mentioned, the epidemiology and the political situation within our organization came together in the fact that we said that we should be looking at the first 2 decades of life. So that is a strategic, but also political decision of our organization. And when we say first 2 decades, that's like from 0 to 19. And so in principle, when we do our programming, when we do our research, our examination, when we're looking at age groups as far as data, then we're predominantly looking at that age group setting, and that's overall as an organization. But absolutely agree that when you're looking at certain types of, and not just falls, but many adolescent health risk issues, that it certainly goes beyond the age of 19. But at some point, the organization draws a line on where we have to do our statistical data analysis. In an informal way within our organization, when we also have an adolescence section and adolescence age group work that we do. And I would say that when we're working with our colleagues in the adolescence health development, that there are many times that discussions and implications of what we're doing from programming and policy does extend beyond 19 and looks at age groups such as up to 25. But when we're specifically doing literature reviews or systematic data analysis, then those are sort of the age groups that we follow within our organization mandate. And actually, even for our own organization, it's only been these last few years that we've gone beyond the age of 5. And internally within our own country offices, we're having to work very, very hard to get colleagues to program and be interested in activities beyond the age of 5. In many of our low and middle income countries, their focus is still on under 5s, which is why I gave the example of the home visitation programming on falls, and how that has some at least ability for us to do programming in countries and get them to use that as a starting point and integrate falls into general home safety activities. Because right now, like many organizations, people are overcommitted, do not have the resources from time or people to get the job done. And so our approach is to look at mainstreaming as many activities as possible, and that includes falls. And if we can get people at this point engaged in the 5 and unders, and then move to those other age groups to include up to 19, and where possible beyond. So absolutely agree with you, Jonathan. It's just strategically where our organization has made that age group decision. I hope that helps clarify.
Thank you, Joanne. Terrific. And if I can just pass over to Margie, I see you've got your hand up to take a further comment.
Yeah, thanks. Great question, John, and great response, Joanne. And I think one of the ways that some of this can be overcome is by, again, not looking at injuries in a silo way, but trying to broaden the area that we work in. And one of the possible areas that UNICEF could do this is by working through the mother and child programs, because we know that young mothers, and many mothers are in their teens, are extremely vulnerable themselves, not only to injury themselves, but lack that information perhaps around how to keep their own children safe. So again, it's an issue of empowering mothers and including those vulnerable groups.
Thank you, absolutely. And I know certainly within the Kidsafe Victoria and Australia context, it's been a challenge for us as well to extend the interest, if you like, from the under fives into the older age groups. And it is a challenge. And the part of the approach we've taken is if you can influence and get access to the mothers in particular when they have the baby or before having the baby, and engage them in injury and injury prevention and in understanding what some of those risks are. If you can get them then hopefully you can retain them through the life of their child and other children. So absolutely understand it, but it is very, very challenging. Shanthi, can I pass to you?
Yes, thank you, Erica. I think one of the slightly different aspect of this particular issue, which is not so much about what organizations do, but even what researchers and research groups interested in adolescent health tend to do. So even when people have made that transition and say adolescence is really important, we're living in a time where this is the largest generation of adolescents the world has ever had. That's thanks to a large extent the success of the MDGs and good work in the under 5 age group. So good on you guys for having done excellent work. They're living now to the adolescent age group, and we have this huge population, but it's not huge. And what I'm saying is it's the largest we've ever had that age group to being. What I find as a adolescent health researcher going to research international conferences, really hard to find injury presentations. If they are there in those adolescent conferences, they're usually on interpersonal violence. It's not on unintentional injuries, certainly not on road injuries, even though that's the biggest killer. And most of the adolescent health research agenda is, and not surprisingly, very strongly influenced by education access issues. Nobody's denying the importance. And women, young girls and women issues, reproductive issues. These are huge human rights issues, and I don't want to take any shine away from that. But I'm just stunned. I've often do just a word search on conference proceedings and find it really hard to find the unintentional injury presentations in an adolescent conference. So I think we have to work with our colleagues as well.
Absolutely, and hands going up left, right and centre. I might pass to Joanne first and then to you, Julie, if that's all right.
Thank you, and absolutely agree with the comments have just been made across the board that in Unicef as a large organization, and we do have, like I said, an adolescents health colleague and section, and we have to work very diligently to get injury prevention included in those issues. So even within our organization, and we have working at the global, regional, and country office level to get that activity in there, and to talk about this in a cross-sectoral manner. So not just with our adolescent health colleagues, but then also going to our urban planning colleagues, and then going over also to our not just intentional, but us with unintentional injury, and so it goes on, and education. So we are really trying to as an organization, look at how we, as I said in my presentation, how we mainstream and integrate injury prevention, including falls, within our own organization across many sectors, and then getting our colleagues to work with those diverse stakeholders in those settings at those different geographic regional areas, and making those connections of how we can actually have on the ground activities happening that can be, like I said, integrated, because we cannot do a silo. If people do not have the time, resources, and ability to do that, we need to find ways of making our important issues integrated into how daily lives are happening for children and young people. Thank you.
Thank you, terrific. Julie?
Thanks very much. I feel your pain, Jonathan, I think, on this issue about the lack of standardization of the way that we report children's health data generally, and you know, if you want to try to make international comparisons or comparisons even within countries, sometimes it's hugely frustrating when you find that different sources of data categorize the children into age groups that vary tremendously. And whilst that's frustrating, I think the fundamental issue for me and the work that we've been doing recently in Nepal is the fact that what's more important than the age categories is actually having some quality data that we can actually believe in, because I think that, you know, often the injury collection systems that are available to us are really not complete. Coding is rarely accurate, and therefore we know that the data that is routinely available is usually a huge underestimate of the true burden that is existing. So I think our priority probably has to be focusing on working with the systems that do exist, strengthening them wherever possible, because otherwise we just won't know whether or not the activities that we're implementing are really genuinely making a difference. And I think that, you know, we've got to sort of balance that desire for this uniformity with a reality of actually just working with the systems that we've got so we can really understand what's going on and whether what we're doing is helping.
And I will come back, Julie, to that issue about the data and gathering data and whether it's nuanced enough to be able to actually implement effective controls and strategies for elimination in a moment, because I know that is an issue. But I'll throw to you, Margie, if I can, for a comment that you wanted to make.
Yeah, thanks, Erica. Maybe just want to kind of pivot back to falls a little bit. And while the age issue is really important and data is critical, I still don't think that the lack of robust data should stop us from intervening. I think we know what the principles, and I think the thing that struck me through all the presentations that we've had today is that falls is the leading cause of unintentional injuries, and yet it's not on a global radar. You know, kudos to WHO for putting out the Step Safely technical package. That's great. But how are we going to get, you know, interventions? How are we going to get donors excited about falls? Everybody falls all the time. You know, everybody knows of somebody. I'm sure today you can tell me that you heard about somebody who tripped and fell, or you know, was playing a game and fell, or whatever. So it's kind of, it's not in the uppermost mind of international organizations as well as for donors. What is going to make it appealing? You know, we had hooks for violence prevention, we had hooks for traffic injury prevention, but what's the hook for falls? And how can we move this forward, given that it's a huge burden on healthcare systems? I mean, when you go to the accident and emergency rooms, people are all lying there with their arms in plaster Paris or their legs up in stirrups and things. So yeah, I mean, we do have to address it, but we do have to somehow make it appealing, given the paucity, I think, of the data.
You've just stolen one of my questions that I had for you, which was on exactly that. You know, any ideas from anyone on the panel, and not just around donors and organisations like ours, but government as well? How do we influence them? Because we've got the data, accepting the conversation we just had around comparatives, but we know, and it's in the program itself, we know things like residential building codes, regulations around guards, provision of health and safety information. We know all of this. We understand the lifelong impact. We understand the economic impact as well as the social impacts. So what can we do? And I excuse the terrible terminology I'm about to use, but to make it sexy for governments and others to actually invest and really do something in this area. Any suggestions? Julie, I'll throw to you first and then to Joanne.
Thanks, Erica. I think this is hugely important about how we raise it up on the agenda, and it's clearly, as has been mentioned on several of the presentations today, it's no individual's responsibility, is it? It's a system-wide issue, and we've got to the challenge of raising this issue amongst so many other priorities. So it's actually getting this one to the top of the list. And I think there are two key areas that have a potential to make a big difference in some low and middle income countries. And one of is the human rights agenda. I think that there is a rights issue here. And for quite a lot of countries, actually, that is gaining traction. And actually, people do recognize that inequality and inequity, and that there is a desire to address that. So I think if we can demonstrate how injuries and fall risks in particular are inequitably distributed across society, that is one little lever that we can use. And the other is the one that Margie touched on there, which is the economic argument. These are hugely impactful injuries with regards impact on health systems. And if you can demonstrate the cost effectiveness of interventions to prevent falls and say, look, this is how much your country can save by tackling this issue in this way, that is likely to be something that is going to attract the ear of politicians and financial decision makers. So I think they're two really quite useful mechanisms that we could potentially maybe make more use of.
Fantastic. And I think also if you go as well to the interventions, similar to things that Margie was talking about, and saying if we can't prevent the fall from occurring, how do we reduce and minimize the impact as well, and show some data to show that again, from the economic and the social burden, hospital visit, all that sort of thing makes a huge difference as well. So thank you, terrific points. Joanne, please go ahead.
Great, thank you. And thank you, Julie, for those starting off and those excellent comments. I think those are very valuable and very worthwhile. I think the other challenge is that overall awareness. I think we need to talk about this more, and we need to talk about it really loudly more. And even though, yes, we're all full and busy with so many things, but we have to find a place where people are going to hear about this. And not only is it, yes, it's a systems issue and we have to do this across many sectors, but we also need a champion to take the lead. And often this comes back to health, in that sort of raise the awareness, a coordinating action. It's like when we talked about drowning for the longest time, that it was a Cinderella story and no one wanted to take ownership because it was happening in so many different areas, and so many different ministries had an input or responsibility when we were mapping and how this happens. Does it belong to transport? Does it belong to housing? Does it belong to, and this is a similar issue with falls. It doesn't necessarily only fit into one ministry. And so it's an issue that all ministries need to address, but then who is taking the leadership on moving us forward? There's no commitment from in some courses, in some locations, in some countries, some people are taking commitment, but overall, we need to find and it may not be the same ministry in every country, but we need to find who is going to take that commitment of leadership to coordinate those discussions, to move it on the agenda, to be a government level champion, and to say, how do we, and I say government because I think overall we need this overarching leadership to look at policy approaches to be able to put some of these solutions in the right context and setting to make a difference. And so if we can position this as a rights issue, as Julie said, and looking at the economic arguments and using those hooks, but we still need a leader. We need a champion to sort of put that on the agenda and bring all those different stakeholders and cross sectors together to make a movement of doing that. And when we do that, we can hopefully make some impact and change. And if we try to integrate that into existing strategies. So if it's the national health strategy, but you have those other 15 ministries on board to implement that health strategy, how do we then move commitments through to other sectors to support an overall aim? This could be something to consider as far as approaches as well. Thank you.
Thank you. I completely agree with you. And as you were talking about the different ministries, I was just sitting there nodding. It's exactly the issues that we face here. And going to Shanti's problems, high income countries, we have the same challenges in trying to engage multiple stakeholders to say you actually do have a role to play in this area. And I think Jonathan's expressed it well on the chat here as well. Health owns the problem, but doesn't own the solutions. And that is, isn't it, a key part of the challenge, trying to get everybody together under a leadership group to say we all own the problem and we all have a role to play in the solutions. I'll go to Margie and then to Shanthi. Thank you.
So maybe I just want to throw a spanner in the works again and ask that question, do we really know what works? Because, and I concede, we did the systematic review. The George Institute did the systematic review that is the basis for the StepSafe technical guidelines. 99% of those papers came from high-income countries. 90% of the problem, I think David said, of falls occurs in low and middle income countries. So how can we make recommendations around building codes? Building codes? Seriously? When, you know, the majority of people in low income countries live in shanties, in cardboard houses, in non-standardized building, you know, electricity that's been siphoned from cables, you know, above that run above the houses, etc. So I still think that there is a gap. And I think that going to any donor who will want to understand what is bang for the buck that he's going to give you is going to involve. If I can't say that, you know, these and these and these interventions need to be put in place and they are applicable in less resourced settings, he's not going to put his money there because, you know, he's not going to get a return on his investment. So I still think that we need to understand much more the contextual issues, the social determinants, and how they interplay, link up with some of the other agendas, the environmental agenda, the economic agenda, as some people have already mentioned. And try to push forward that way. I don't have the answer to the question, how do we make this sexier? But it's important to make it sexier. We just have to think as a collective, I think.
Thank you. Yes, it's right, isn't it? It's the systemic, it's holistic, but it's also how do we actually make it relevant within the local context? Because, and I actually wrote down a note as you were with your presentation, Margie, about if I was living in that environment, the last thing I would be thinking of is, do I have a barrier? Because, you know, it's just not going to be on my radar, but actually having a mat that can help reduce, eliminate the harm when the child does fall, now that I would engage with, and that I'm really interested in. So how do we actually also access those community groups and those communities and diverse communities and more vulnerable communities in a way that's relevant for them and is going to make sense to them, and then give them the tools to be able to create solutions that work for them. Yeah, absolute big problem. I think it was Shanthi next, wasn't it? Sorry, thank you. You're all moving on my screen.
Thanks, Erica. I think it's linking a bit to what Margie's just pointed out. One of the things that I've been struck by for the injury prevention field as a whole is, even when we're saying how do we make it sexier, I'm actually interested, regardless of what we want to do, what it actually is. Because if it is false, or even if it is unintentional injury, and we want it at the top of the leaderboard so that people get more attention, or we want it on the leaderboard so that people get it, what do we want taken off it? Do we want, in a country that is dealing with child malnutrition, COVID, tobacco control, alcohol, and other commercial determinants of health, etc., what exactly are we potentially as policymakers asking policymakers to do? Because everybody wants, I mean, we are at risk of actually being part of that silo problem, which is, let's talk about falls today, and we want this on the agenda. And my sense is it does get back to those broader issues that Julie referred to in terms of human rights and I think in the end, it comes down to inclusive, equitable, and enabling environments where people can thrive. Now, the problem is that just sounds very motherhood and apple pie-like, very all-encompassing. And that's the challenge. So how do we move past the way of looking at falls one day and drowning another day and road traffic injuries another day, when in the end, we're all living in the same environment and some of the same communities and children are getting affected by all of them. So I have a feeling this is probably around, and maybe it is a webinar in itself. I noticed John's pointed out that question needs attention about how we get political action and how we make certain political issues basically be able to get past the silos, be cross-cutting enough, but not lose the momentum of change. And it does link into sustainability and climate change and everything else. I have a feeling there's something very big here that we potentially could risk losing sight of, and we need to shift our whole injury prevention process to achieve that.
Absolutely, thank you. And Jonathan has also again put into the chat reports that WHO Europe is going to release around 53 countries in the region, which he again says hopes will stimulate discussion on this economic rationale about prioritising this as an issue. But it's challenging, and when you start to list all of the various bits and pieces and the various things that are important that can have an impact, it's sad that potentially we might need to think about, if we elevate this, what's going to fall off the agenda and what harm's going to occur from that. So again, how do we look at it more holistically and get more people in more areas and departments, if you like, interested in the holistic issue? Very, very difficult. I think I might need a wine. My time, it will be 7 o'clock-ish after this discussion. Can I go to you, Joanne? Thank you.
Great, thank you for that, and absolutely, Shanthi, and Margie and Julie, that we've been talking about the broader issue, and I really want to emphasize the comments made on environment. This environment and climate is really important and at the top of mind for communities, for young people, for governments. And so I think, again, if you look even at the images we as presenters have used throughout our slide decks today, we all have these environmental settings that are really cross-cutting the fact, like one of my slides are talking about context and setting the right for a healthy and safe environment. And we've got, and if you weren't understanding what presentation you're in, you would think we were in a drowning prevention session. I have 2 kids on this really large disc on this huge water area. And yet we're talking about how cross-cutting that falls into water. Is that a fall? Is that a drowning? What is happening in our environment? Margie's showing children playing in garbage dumps. Again, these are also environment issues that we can be integrating our agenda on falls within the broader context. And I think this is a really important point, that we can be looking at how do we look at communities overall, and how do we, so that we're not asking communities to pick one issue over another. We're looking at that for that overall, what is that context and setting that we need to ensure that children, families, communities overall have a healthy and safe environment? And what are those overall things in that context and setting that need to be applied? So, and how do we take those high income country solutions, but how are they effectively understood, and how do we translate that knowledge to that context and setting? So I agree with all the comments that we made, but we don't want to be competing against anyone. We want to be integrating as best as possible for an overall best community that people can live within, live, work, and play. Thank you.
Thank you. And you touched on then work, which is a question I did want to ask, because I think that's one of the other areas that needs to be integrated if you're talking about community, and particularly listening to the presentations from each of you there. The life of a 15-year-old child in a number of the countries you were talking about is very different to the life of a 15-year-old where I live, when they would be at school. So is there a role in this, and sorry, Julie, I'll come to you in a second, is there a role in this again, or some learnings we can take from employers? Because there's a mix of workplace in here as well, isn't there? And the things that you were talking about with children at 15, they're at work. So can we engage, or are there any learnings from that environment that we can bring into the conversation here to get a focus more around, well, it's also a workplace. So we might be looking at home and home safety or whatever it might be, but this is a workplace for a lot of these younger people. Are there any learnings there? How will we potentially integrate that into the solution, if at all? Broader general question to contemplate, maybe. Yeah, cool. Julie.
Thanks, Erica. I think the bottom line here is, isn't it? We know that the most disadvantaged in the world are those that are most at risk of having injuries, having the risk of communicable diseases, the risk of having non-communicable diseases. So, I mean, the bottom line here is actually, how do we help people out of poverty? How do we help people to tackle those wider determinants of health so that they have a healthy home, they have a healthy workplace, they have a healthy environment in which they live? And the challenge is that for individual countries, tackling everything all at once is just not a reality. They need to have some focus. So I know we want to avoid being in silos, but actually we need to have examples and concrete things that governments and decision makers can actually latch onto and make a difference. And the clear thing that comes across to me from the presentations we've had this morning is there is no one size fits all, is there here? We've got to actually understand our local context. We've got to understand the local priorities. So for me, I think one of the key things for going forward is we've got to do a lot more active listening. We've got to listen to communities about what concerns them, about what their solutions are. We've got to listen to governments and decision makers about where are they prepared to invest, what is their level of knowledge, where are their gaps, where can we support them? And I think that unless we actually do better listening, we're not going to be able to actually engage the people that we need to engage in order to start to make a difference.
Yeah, absolutely. And on that, before I throw to you, Margie, on listening, one of the questions that Jonathan asked earlier on in your presentation, Julian, again comes to the specific context in Nepal, was what do we know about fall injury risk in the context of risk-taking behaviours between, excuse me, I don't have my glasses on, prepubescent boys and girls and in low-income countries. And is there anything that you can discuss or point to in that? Is there a difference? What's the data show?
Sorry, was that specifically addressed to me?
Yeah, sorry, yes.
I think, to be honest with you, we don't have the knowledge yet. I mean, certainly I haven't seen the data in a Nepal context related at that level of granularity. I would love to know more about that. You know, we need to really dig into the lived experience of those of prepubescent and pubescent children to actually understand what risks they're taking. I mean, there will be risk taking in the adolescents. I mean, it's what we expect, but the opportunities are very different. I mean, one of the key things that's an aspirational thing for a young Nepali at the moment is actually to own a motorbike. And, you know, their risks are actually very much related to actually road traffic injury in particular, which is why I think for the falls in specifically, it's those prepubescent children where actually there is a real focus that needs to be focused on for falls prevention. But adolescents, I think, have other priority injury risks that we should perhaps be focusing on.
Thank you, and sorry for the surprise question. Thank you. Margie.
Yeah, hi, thanks, Erica. I wanted to circle back again to kind of where to start to push this momentum forward. And I think one of the things that struck me is, as I look at the panelists, and as I look at the participants, to be perfectly frank, we are preaching to the choir here. So Shanthi and I may, in a previous life, have both lived in low resource settings. I think both of us can no longer claim to be to be from developing countries, so we don't even count. So I think one of the first steps that we really have to do is take this discussion to the countries and regions where this is a major issue. And so while this is a good start at a global level, I think, you know, John, you in Euro amongst your low resource settings in an appropriate language should be having this conversation, and likewise in Asia, and likewise in Latin America, and likewise in Africa, etc. Engaging in think tanks with local researchers to think through some of the guiding principles and then the context specific. And even, you know, we talk about, we at the George Institute have an Africa initiative, and they keep talking about an Africa initiative. And I keep saying, hey guys, Africa is not a homogenous continent. There are, I don't know, 50 something countries, each of them extremely different. So context is very local. So I think we have to reduce down these discussions that we're having to really local areas, and then get support for interventions so that we can have some case studies and show that things are working at a local level, because that kind of breeds interest and will encourage further donations, we hope, from other philanthropists, and things could roll from there. But we really do need to reduce down.
Absolutely. I think it's a nice end, I suppose, from my perspective, the discussion. We start global, but then really we come down to the fact that we do have to really start local. But I think you mentioning start the conversation, that's a really big part of it. And if I can just say thank you to all of you from my perspective for a thoroughly enjoyable, engaging and enlightening conversation, which has, I think, and will help me certainly have conversations around these issues at a more local level. So I really appreciate that. Thank you very much to all of you for your time and your expertise and for sharing. It's been fantastic. And if I may, Caroline, I will hand over to you.
Thanks so much, Erica, and thank you for your excellent facilitation skills. That was a really engaging conversation. I'm sure will keep me awake tonight around the very haunting question of what is our hook for falls? What broader agenda should we be aligning with to further our work, but still to not distract from the key issue that we're trying to address. And as many speakers have said now too, this is the beginning of the conversation. We want to have more discussions around this issue with you. We want to engage a broader, more diverse people more broadly in these sorts of conversations we're having. And again, yes, Step Safely is an excellent step towards this, being led by WHO. Off the back of that comment around the beginning of the conversation, I'd now like to hand over to Professor Richard Franklin from J.S. Cook University. So Richard has a focus on improving health, safety and well-being, the focus on injury prevention, health services, rural populations, those working in agriculture, disasters, resilience and drowning. And very importantly, Richard is also the chair of Safety 2022, which is the 14th World Conference on Injury Prevention and Safety Promotion. And Richard, I'll just hand the floor over to you to give a bit more information about this upcoming event.
Well, good afternoon, good evening, good morning, everybody. And thank you, Caroline, for introducing me. I'm here in Townsville in the tropics, and I thought as we were talking about children and falls, and it did come through, which was really great to hear, I would mention my three boys that you can see in the picture there, the two twins and the older one. And when we're talking about falls, my boys managed to fall pretty much everywhere, from trees, on the ground, walking, playing sport, going up hills, coming down hills, in the house, falling off bed, falling off chairs. You mentioned it, they fall off it. Now, very luckily, none of them have been significantly injured from it, but it did remind me as part of this growing up that there is an element, and thinking about it from a father's perspective about wanting my boys to experience life, but also protect them. I think there are some real challenges, and it was interesting to hear the conversations around that and thinking about falls for children. And it was good to see that people were talking about context. The picture in the background, you can see this is about 400 kilometers off the coast. It's Hughenden. It's really rural, and the risks there are very different. And I think, you started to talk about that, but not only in low and middle income countries, but also in high income countries, there's a lot of variability, which brings me to very much wanting to acknowledge the traditional owners of the lands on which we're meeting today. I'm here in Townsville, which is the Bindal and Woogarabba people land, and I pay my respects to their elders, current and emerging, and thank them for their custodianship of the land, and say Wadamuli to you, which is welcome or hello in the Bindagubba language here in Townsville. So the conference, which I'm really here to talk about, is coming up. We're having it in November. We're having it in Australia, and it's really starting to shape up and be very exciting. I'm looking forward to it. I'm looking forward to getting through all the work part of it, because there's been over 600 abstracts, which has been really great, and over 50 workshop presentations that people have put forward. We're in the process of sorting this out, and hopefully in the next couple of weeks, if you put an abstract in, you'll hear whether you've been successful or not and what type of presentation that you've got. It is hybrid, so there will be some online. There'll hopefully be lots of people in person, and we want you to come to Australia and enjoy that. And I think we want to get back together after not being able to catch up and connect with each other as part of that process. Really great to hear what was also being talked about the need for better evidence about what we do. This is what the conference is working towards, making sure we've got a strong epidemiological approach. And I think we do that reasonably well, although I do take Margie's points that there is still a lot of gaps in our data and understanding, particularly in the fall space, but also thinking about the policy and the practice outcome of it. And I think the evidence base is actually very weak for falls, having done a number of work around this, and also thinking about the farming environment, which I do a lot of work in. We actually don't know what works. We don't know what works outside of metropolitan centres. Even within metropolitan centres, we're unsure. And then in low and middle income countries, we also are not too sure about what's going on as well. But this is what we're going to try and do with the conference, is bring you on that journey across all those different areas. There'll be workshops on the Sunday. There will be a child workshop on the Sunday that we're just working on at the moment. And there'll be lots of child material throughout. There's a little bit of adolescent stuff. So whoever raised that, really good point about adolescents and needing to delve into that in a bit more detail. And we might even see whether we can pull that out as a stream. There'll be the concurrent sessions. We've got some really great keynotes coming along, thinking about some of the wider challenges, thinking about issues around determinants of health, thinking about some of those challenges about how do you finance stuff, or for want of a better word, how do we make things sexy? So really trying to work through and think about what we need to do from an injury prevention perspective, bring us together. Hopefully the workshops are going to be really interactive and engaging as part of it. Hopefully we're going to think a little bit more about where we're at and how we can connect and where we need to go. And it's been some really good conversations about, the things that we need to do and the processes that we need to step through. I also want to do a big call out to WHO for this series as well. It's been really interesting having now sat through all three of these and looking at it, and the complexity of falls is amazing. And I think this is a challenge for us across injury, because when you then step into road safety, there's another level of complexity. When you step into drowning, there's another level of complexity. There's certainly overlaps around this in the way that we talk, and hopefully we can learn from each other as we come into the conference and think about what we're doing. So I'm here to encourage you to come along. I think it's going to be a brilliant conference. I think we're going to have lots of great speakers. We've got lots of spotlight sessions. Children is one of the spotlight sessions that we're looking at. We've got violence, we've got drowning, we've got road safety, we've got workplace health and safety playing out. We've got some policy coming through as well. We've got falls, we've got sports and recreation. So all areas that overlap with a lot of the work that we've been talking about today. So really, it was a really quick chat. Thank you very much for having me. Thank you very much for this series. Well done to everybody that's been involved. I've really enjoyed it. I hope we hear more about it, and we'll certainly be hearing more about falls at the conference. So come to Adelaide, be part of the conversation, be part of what's going on, and I look forward to seeing you there in November. Thanks very much, and follow the website, sign up for the Twitter, and on the website you can get the newsletter as well, and we've got a regular newsletter going out about what's going on. That's how you keep in touch with us. So thanks for being part of it. Thank you very much for having me, and back over to you, Caroline. Thank you.
Thank you so much, Richard. And thank you everyone for joining, of course. These webinars will be recorded and made available online for watching, for sharing with other people more broadly as well. We'll also be developing some summary documents that really summarize not only the presentations, but the really rich discussions we've had at the back end of each webinar. In saying that, this is our third and final webinar. Once again, a huge thank you to our excellent speakers and Erica for your excellent facilitation skills. And thank you to all people who have joined us today. We look forward to picking up this conversation again through Safety 2020 and through other opportunities as well. And thanks all. It's been a real pleasure. And I hope everyone has a nice morning, afternoon, evening. Thank you all.